We'll start our next talk. Like, hormones get no respect. We think of them as the elusive chemicals that make us bit moody. But these little magical molecules do so much more. Dr. Pankaj Patel sir is going to talk on some clues this molecule throws, and his talk is about seeing the signs of endocrine clues in pictures. I welcome Dr. Pankaj Patel sir.
As the topic said, it's seeing the sign, endocrine clues in pictures. ઘણા કહેશે કે આજના જમાનામાં આટલા એડવાન્સ ટેસ્ટ થાય છે તો આવા બધા સિમ્પલ પિકઅપ્સ પેશન્ટ્સની શું જરૂર છે. બટ યસ, તમારા માઇન્ડમાં કંઈક હોય તમે જુઓ તો જ ઇન્વેસ્ટિગેશન કરાવશો ને. રાઈટ. સો લેટ્સ સી, we'll discuss some of the images, how these images I have taken in my clinic. All the patients are mine. I've seen over a period of time. Some of the images are clear, some of the images are not typically taken for that purposes. પછી લેટર ઓન રિયલાઇઝ થયું કે ભાઈ ના આ વસ્તુ હોઈ શકે, એટલે એવું બધું થોડું કોરિલેશન છે. સો વી સ્ટાર્ટ વિથ અ વેરી બેઝિક ઇમેજ. સો ધીસ ઇઝ અ 1 minute pointer, right? So this is a simple image of a hypertrophy, insulin site hypertrophy. બહુ બધી વખત આપણે જોયું છે પેશન્ટ, એટલા બધા ટાઈપ 2 ડાયાબિટીક પેશન્ટ, ટાઈપ 1 ડાયાબિટીક પેશન્ટ જોતા હોય, ઘણી વખતે આટલા હાથમાં જોઈએ, બીજી ઇમેજીસ જોઈએ તો યુ મિસ્ડ ઇટ. સો યુ હેવ ટુ રિમૂવ ઓલ this part and you can see there is a significant hypertrophy over this. This is called insulin site hypertrophy because insulin is a lipogenic hormone. Why this happen? Not proper rotational, that you know કે ભાઈ જગ્યા બદલતા ના હોય, but one of the other reasons are improper size of the needle and taking of a cold insulin. પેશન્ટ્સ ફ્રીજમાંથી રિમૂવ કરે, તરત લઈ લે, આઈડિયલી 30 મિનિટ સુધી બહાર રાખવું જોઈએ, રૂમ ટેમ્પરેચર સુધી, અધરવાઇઝ ધીસ ઇઝ પ્રોબ્લેમેટિક. Ask the patient to change the position over a period of the time. It might resolve, it might not resolve. What happen if it progresses further? Then it will cause a lipoatrophy. So in this image you can see there is a lipohypertrophy and there is a lipoatrophy. Because there is an immunogenic response of an insulin, that's why there is a loss of a subcutaneous tissue and you will have a lipoatrophy. You can identify in these pictures there is a lipohypertrophy, but there is a dimpling. This is the lipoatrophy. In this picture you can see very clearly. What happened practically? There is a very high glycemic variability. રિસ્પોન્સ ન આવે, ક્યારેક આવી જાય, ક્યારેક આપણે એમ થાય કે આટલું લેન્ટસ દીધો કેમ આટલું થયું, સડનલી એટલા જ ફૂડથી હાઇપોગ્લાઇસેમિયા થઈ જાય. સો દેર ઇઝ એન ઇનપ્રેડિક્ટેબલ ઇરેટિક રિસ્પોન્સ ઓફ એન ઇન્સ્યુલિન because of this condition, and generally there is a very less reversibility of it. So as a physician, when we see a patient, it's a good idea to check all the sites and it is very advisable that you palpate it. ઘણી વખત આપણે જોઈને એમ કે ના બરાબર છે, એમ નહીં, you just palpate, you just stress that with your finger, then you realize how much is the thickening is there or not. So this is about a lipohypertrophy and lipoatrophy. Nowadays not seen very common, but still it is there. ઘણા પેશન્ટ્સ હાથમાં બાવડામાં લગાડતા હોય, પગના કાફ મસલમાં લગાડતા હોય. So this is a wrong insulin side. You can see there is a typical lipohypertrophy of a calf muscle. So absolutely a wrong side છે લગાડવાની. Now moving towards a little complex cases of related to the lipid and adipose tissue. This is a lady of a 17-year diabetic patient, poor compliance, offer of insulin, no weight changes, no other insulin, no other autoimmune disease. એટલે એવું સરપ્રાઇઝ થાય કે આટલી યંગ ડાયાબિટીક પેશન્ટ છે, ઘણી વખતે ઇન્સ્યુલિન બંધ કરી દી, આ છે તે છે, તો એ કેમ ડીકેમાં નથી જતી? પુઅર રિસ્પોન્સ, પુઅર કમ્પ્લાયન્સ. Many of you can make out from the faces there is a typical loss of a subcutaneous face or subcutaneous tissue over the face, and there is a prominences in the hand. તમને આમ આપણે બોડી બિલ્ડિંગ કરતા હોય હેન્ડ લાગે, પણ પેશન્ટ જનરલી ઇઝ અ હોમ મેકર. સો આઈ રિવીલ ધ ડાયગ્નોસિસ. This is called a lipodystrophy syndrome. The previous was a hypertrophy, atrophy, and this is the dystrophy. I'll show some of the more cases. This is presented with hirsutism, and on diagnosis found to have diabetes, and you can see from the face there is a loss of a breast fat tissue. There is a prominency over here, and this is the face. So basically there is an atrophy of a fat tissue. So fat adipose tissue, it conserves the energy. So there is a redistribution of the fat from the area it should be there. It redistributed to the other places like liver and pancreas and all that thing. So that's why it creates a situations of abnormal metabolism and it increases the insulin resistance. So generally they are not as symptomatic. They don't come to you for diabetes purposes. But if you have something in your mind that they look like this, then you can investigate. And this patient presented with hyperandrogenism and lipodystrophy syndrome. Some clues you can get from a lipid profile also. There is a higher triglyceride level, low HDL levels, and some kinds of insulin resistance in the lipids also. When more patients presented with the poor facial hair and found to have high diabetes, borderline higher HbA1c levels, and this is the, again in like similar lipodystrophy syndrome. ઘણી વખતે આમ પેશન્ટનો ડાયગ્નોસિસ થઈ શકે પણ એના સગા ઉપરથી થઈ શકે. ધારો કે આ પેશન્ટ આવ્યું જે ચાઇલ્ડ ગર્લ છે અને તેના મધર છે. So there is no typical facial abnormality, but there is an prominence veins in the hand, and this is the mother's hand. એટલે ખ્યાલ પડી જાય કે this is the typical of a familial congenital lipodystrophy. So we did a genetic test of the patient and found to have a congenital generalized lipodystrophy. So this is a basically spectrum of a disease. Sometimes it can be seen in the face, hand, gluteal region and all that things. Once you see this kind of a patient over a period of time, then you realize then in the first time in this patient I've seen first time in my clinic with uncontrolled hypertension, and then we can surely say this is the lipodystrophy syndrome. So click these pictures in your mind, then this kind of a situations, if you see this patient diabetic, obese, not behaving in a proper way, then it could be like that. We'll see some of the other cases of a lipometabolism, a lipid metabolism abnormality. This is called a tendon xanthoma, right? Familial hypercholesterolemia. Some of these cases are isolated, some of the cases are familial. Why we want to pick up is because their LDL is very high, generally in the range of 200, 250. We have some of the patients with a familial hypercholesterolemia, they have a LDL receptor mutation and their LDLs are sky high, like 600 and 650. Why we can if we able to recognize early, because there the premature CAD chances are very high. Xanthelasm, I am sure that ઘણા સિનિયર્સ ફિઝિશિયન છે, આપણે બધાએ ઘણા જોયેલા હશે. એક જમાનામાં જ્યારે ટેસ્ટ નહોતા થતા ત્યારે પણ આવા બધા ડાયગ્નોસિસ ફેસ ઉપરથી રિકોગ્નાઇઝ થતા. This is a xanthelasma. They are isolated. They have a mid to high range of an LDL. This is my patients of eruptive xanthoma. The previous one was having a high LDL level. This patient generally presented with the high triglyceride level. They generally triglycerides are like 10,000, 15,000, more than that. Why it's important to diagnose and treat? Because they have a high risk of pancreatitis. The previous as a CAT, they have a high risk of the pancreatitis. Sometimes the symptoms are not very high because there, as I said, it's a spectrum of disease. When you are picking up, you don't know when you are going to pick up. This is an early form of this. ઘણા તમારા diabetic patient ને ક્યારેક આવું થતું હશે, હેન્ડમાં આટલા બધા ના હોય, sometimes less હોય, then it's good idea to check for an LDL level, lipid profile levels, because they are little bit itchings and some of the eruptions are hand in the leg. So that's called an eruptive xanthoma associated with the high triglyceride levels. Now moving towards some simpler cases, childhood obesity with બધાને ખ્યાલ જ હશે. This is called an grade 4 acanthosis. બે ટાઈપની childhood obesity. Those who have an obese to begin with, ઘણા children પહેલેથી જ hefty હોય, familial obesity હોય, એ લોકોના hands and strong way. They don't have this much of acanthosis. They don't develop also problems. They generally becomes obese and high BMI. They don't. Those who received a significant calorie, their intakes are very high. They develop this kind of an insulin resistance and acanthosis. Sometimes patient don't come for this. Patient obesity માટે જ આવે અને આનો પ્રોબ્લેમ ન હોય કે સાહેબ અમે ઘસીને કરી નાખશું એમ, પણ એ કાંઈ જાય નહીં, બરાબર? ગમે એવું સાબુ સોડા ઘસે ને તો એ આમ ન જાય, બરાબર? Why we need to emphasize them is that this patient developed a diabetes in a future, though you might have a borderline high HbA1c levels or some biochemical abnormality like little bit high SGPT, SGOT. એમ કે સાહેબ આટલું તો અમારો છોકરો છે જ પહેલેથી, મને કાંઈ વાંધો નથી. But I'll show you some of the cases where what will happen if we don't treat this patient on time, right? So this is the case of one young patient, 17-year-old, presented with the decay, very high insulin requirement. This is the clinical pictures of a patient, thoda out center છે, clinical pictures of a patient. But now you know this is significant higher acanthosis level, though the patient presented with a DKA. This is the insulin requirement. My history picture, કેટલું insulin requirement છે 70 100 units almost. DKA બધું high જ છે, બરાબર. So back of the mind is a type 1 diabetes. Treat as a type 1 diabetes. But why it is important? That's why that you have an n number of tests in your laboratory and available. But your eyes are important. Your eyes are here. You know this is the obese patients. This is the acanthosis significant patients. Take a history. Gain a 10 kg, 15 kg last couple of months, couple of years. That means you are dealing with probably early type 2 diabetes. So how can you confirm it? So I've treated with the starter obviously on insulin. See the lipid profile. There is a see the blood sugar chart, very perfect control. There is no ups and downs. This is the HbA1c to begin with. We don't expect this in a type 1 diabetics. We expect in a type 1 diabetes little here and there. You can get some clues from the lipid profile. Type 1 have a high DG, but type 2 early, those who have a high LDL, low HDL kind of a things. So we started on an metformin and other treatment, and now a patient is on got an HbA1c of 6. So HbA1c 6 is also not possible in a type 1. Those who are treating a type 1, they know it. So retrogradely that you realize this is not a type 1 diabetic patient, this is a type 2 diabetic patients because of a severe insulin resistance. So that's why I said why it is important. If you pick up on a time before they got a diabetes, we can just ઘણી વખતે સગા આવે એના છોકરાને લઈને તો ખાલી આપણે જાણતા હોય તો કહી શકીએ કે ભાઈ ધ્યાન રાખજો નહીંતર આમાંથી કંઈ પ્રોબ્લેમ થઈ શકે. We did get antibody, that was negative. Can you guess what are the abnormality over here? Yes, very subtle features of acanthosis. Anything else? Skin tags are there. So this is recently 2 days back I've taken these pictures in a clinic. Patient comes for a thyroid. વિદુષભાઈ આનું ध्यान રાખજો. આ skin tags છે. As I said, it is spectrum of a disease. ઘણી વાર કે સાહેબ આ તો ઝીણું અમારે બધાને થાય છે. But when you have this kind of a pictures, then it is definitely obvious. This progress to this. So this patient, if you do HbA1c, બધું fine જ આવશે. But if you follow that over period of the time, they developed in diabetes, obviously, because this is strongly associated with the insulin resistance. So this was about the lipid and lipid and adipose tissue related problems. Now we quickly moving towards some of the endocrine cases. I'm not going to details, just the pictures are there. You will be able to identify easily. This is the primary adrenal insufficiency. Typical darkness over the face, pigmentations, tongue dye, blackness, mucosal pigmentations, weight loss. But as I said, જ્યારે classical pictures હોય diagnose કરવું easy છે. This patient is not having that much of symptoms. એને એટલું બધું weight loss નહોતું, એટલું બધું કાંઈ નહોતું, but having severe pigmentations over the tongue. So every time you just see the patient at a time, follow them 3-6 months, keeps your eyes open. Sometimes you may not find all the things together at a time, but over period of the time, disease evolve. 2 pictures, diagnosis. આમાં તો easy છે યાર. Yes, thank you, sir. This is not an endogenous, this is the exogenous Cushing's. Right? There we expect generally કે ભાઈ આ બધા endogenous Cushing's હોય, આ exogenous Cushing's છે, આપણા મસાલા પાવડર ફાકી લઈ લઈને બધું થાય છે, રાઈટ? અને if you see there 8 to 10 files, ઘણી બધી ફાઇલ જો પેશન્ટને કાંઈ ન થયું 8-10 વર્ષમાં એટલે સમજવાનું exogenous જ હોય. જો endogenous Cushing's હોય તો 2 કે 3 વર્ષમાં જય શ્રી કૃષ્ણ, બરાબર, રાઈટ? So if you have this kind there, because if you stop their other medication, આપણી લખે તો એનો પ્રોબ્લેમ થાય એટલે 2-3 દિવસમાં આપણને બદલી નાખે પાછી ઓલી ચાલુ કરી દે, રાઈટ? So they keeps on moving. So why we need to treat it? Because you checked for an cortisol level. If it is a low, that means it's an exogenous Cushing. Put them on a physiological steroids. Explain them કે ભાઈ આ ઘટતા થોડોક ટાઈમ લાગશે, અસર ઉતરતા થોડીક ટાઈમ લાગશે. Otherwise, over period of that time, they develop pains, back, neck, diabetes, and n number of the problem. I think you all are aware about it. Metabolics, avascular necrosis, many things can happen. So this is the exogenous Cushing's. They are puffiness of the face. Typicals are there, but stria એટલું બધું typicals ના હોય. But common history હોય કે સાહેબ ગમે ડૉક્ટરની દવા લઈએ 5 દિવસ લઈએ પછી એમ કે સાહેબ ઓલી તો લેવી જ પડે છે, 2 દિવસ એની અસર રહી એટલે diagnosis is confirmed. Endogenous Cushing's can easily identify with the stria because, but the problem is this is a rare endocrine disease. એટલે આપણે બધામાં ટ્રાય કરશું તો અમે એક કે 2 વર્ષમાં એકાદ પેશન્ટ જોતા હોય, 2 પેશન્ટ જોતા હોય. So endogenous Cushing's is rare, but it is important to identify because the mortality rate is very high. Cushing's stria typical, we check for an cortisol and then series of the test and then lead to an underlying diagnosis. Two other phases. Any diagnosis. Subtle, yes? Okay, this kind of phases are similar with the connective tissue disease, but this is not a connective tissue disease. Any other thing? Connective tissue disease and the scleroderma is a typical of, but they are not having in this. Now, see the subtle features of a face. There is a loss of an eyebrows. There is a wrinkling of the skins, loss of an like glows over the skins and all that thing. So this patient is having a chronic estrogen deficiency, cortisol deficiency, thyroid deficiency. જે ખાલી hypothyroidism હોય ને તો typical swollen face થાય. If you have altogether deficiency, now many of you have guessed rightly, this patient is having a panhypopituitarism Sehan syndrome. Typical તમને wrinkling જોવા મળે, loss of the estrogen. We treat them with a hyzone and thyroids and sometimes estrogen if it is required. Two other phases, diagnosis clearly written, acromegaly. But why I kept these two pictures of my patients typically is like this patient is not come to me for acromegaly. They came to us for an sugars, and these patients came to us for an infertility and some menses related issue. But the facial features are so subtle. If you ask them in a detail that if there is is there any enlargement of the lips, nose, and these eyebrows. So after asking 2-3 times or to the patient, to the relative, કે ના ના સાહેબ ઈ તો આ ધીમે ધીમે થતું રહે છે, but you just check the photograph, just check with their sisters or husbands, and then you realize, because this is, if you treat in like thyroid, menses or whatever, it is not going to have any outcome. You have to identify the underlying disease and treat an over period of treat an underlying pituitary lesions and treat accordingly, surgery or whatever the things. A young lady, palpitation and high BP. So પહેલી વખતે પેશન્ટ આવ્યું ને ત્યારે અમે મિસ કર્યું, બરાબર. Then second time we have seen that this kind of an like hemangioma on the chest. Why I'm keeping this in a physician forum? ઘણા બધા પેશન્ટ્સ તમારા હાઈ બ્લડ પ્રેશરના આવતા હોય. Just see their neck, abdomen, face, hand and leg. Sometimes you can able to find out some of the clinical, some of the clues which will lead to underlying diagnosis. I'll reveal the diagnosis of this patient. Patients obviously came to us with adrenal lesion. અમારે કરવાનું જ હતું બધું adrenalનું, but this taken us to a particular disease which called an VHL, von Hippel-Lindau syndrome, where you have a capillary hemangioma. So sometimes the spot diagnosis from the chest. This is the photograph after the surgery. There is a regression in the lesion. We sent for a genetic test which came positive for the VHL. Very simple, knuckle pigmentation, B12 deficiency, because significant low levels of the B12 over period of the time increases the melanin and it deposits in the skin. એક લેડી ડાયાબિટીસ માટે આવ્યા, રેગ્યુલર હિસ્ટ્રી આપણે લેતા હોય. બે હિસ્ટ્રી બહુ ઇમ્પોર્ટન્ટ હોય, એન્ડોક્રાઇન પોઈન્ટ ઓફ વ્યૂ અને અધર ફિઝિશિયન પણ લેવી જોઈએ. બે હિસ્ટ્રી, રિકરન્ટ ફ્રેક્ચર થાય છે કે નહીં અને રિકરન્ટ રિનલ સ્ટોન થાય છે કે નહીં, બે વસ્તુ પૂછવી જોઈએ, કંઈક તમને ક્લુ મળશે. લેડીને પૂછ્યું કે ભાઈ ફ્રેક્ચરની હિસ્ટ્રી, જે મેડિકલ ઓફિસર પૂછતો હોય કે હા સાહેબ એ તો અમારી તાસીરમાં જ છે, કે અમારા સગા અમારે મમ્મી પણ બધાને, આપણે કેમ ન કહેવાય ગેસ તો અમારે કે બધાને છે એમ, બરાબર. ફ્રેક્ચર બધાને ના હોય એમ, એની તાસીર ના હોય એમ, રાઈટ. સો એ કે ના ના મારી બેન ડોટર આવી છે ભેગી નાની, એને કે હમણાં થોડાક દી પહેલાં જ થયું હતું, મેં તો બતાવો જી ડોટરને એમ. સો ધીસ ઇઝ ધ આઈઝ ઓફ એ પેશન્ટ એન્ડ ધીસ ઇઝ ધ પિક્ચર્સ ઓફ એ ડોટર, same days as this. So this is the typical blue sclera. We sent for a genetic testing and came positive for osteogenesis imperfecta. Sometimes you don't know that what kind of abnormality will associated with the underlying things, because treating the bisphosphonate on time will definitely improve the life of a second person, because એના તો fracture છે જ, પણ the girl will definitely will not be a significant problems over period of the time. So I'll skip some of the slides for I think 2-3 minutes. Fine. ઘણી વખતે ઇમ્પોર્ટન્ટ થાઇરોઇડની ગોળી જોવી છે, પેશન્ટ કરતાં જોવી જોઈએ. ભૂકો થાય, ટેબ્લેટ્સના ઇસ્યુ હોય, એ પણ પ્રોબ્લેમ્સ થતા હોય છે. જ્યારે થાઇરોઇડ્સમાં વેન યુ હેવ એન સિગ્નિફિકન્ટ લાઇક problems of anemias and like nutritional deficiency, go for an celiac testings. One of the patients like coming to us for an hypothyroidism, you can see there is a typical vitiligo, hand vitiligo. Hand vitiligo is a significant association with hypothyroidism. It's a very common disease associated with the hypothyroidism. તમારા diabetic patient hand vitiligo હોય તો check for an hypothyroidism. There is an strong an association with that. Patient with a hypothyroidism and the scalp lesion. ઘણા આ પેશન્ટ એમ થાય કે આવું તો સાહેબને શું બતાવવાનું, આપણે તો થાઇરોઇડ માટે આવ્યા છીએ. પણ this is the psoriasis which is a strong association with the hypothyroidism. Two share common autoimmune disease, sharing the common underlying situations. એક પેશન્ટ મોકલ્યું કે ભાઈ અર્જન્ટલી આને લઈ લો કે ભાઈ એને યુએસજીમાં થાઇરોઇડ ગ્લેન્ડ જ નથી બતાવતું, થાઇરોઇડ ફંક્શન નોર્મલ છે અને there is no thyroid gland in the sonography, right? What to do? Patient is asymptomatic, mild pain over that. So just open the mouth. You can see there is a lingual thyroid classically seen. So secret lies in the mouth and there is a lingual thyroid. Nothing to do, reassure. And if developed in hypothyroidism, then you just treat it. My colleagues have shown typical cases of solid nodules and all that things. The old lady with a hyperthyroidism, any abnormality in the neck? આમ જો તમને કાંઈ નહીં લાગે. But now you compare both the muscles. There is a prominency over here, there is a no prominency over here. Right? So we don't check generally sonography in hyperthyroidism. કોણ કરાવે સોનોગ્રાફી? કરવી જ ન જોઈએ હાઇપરથાઇરોઇડિઝમમાં. ગ્રેવ્સ ડિઝીઝ હોય તો સોનોગ્રાફીની શું જરૂર છે? But when you have a kind of this clinical examination before doing a test, now we offered a thyroid scan directly and to found a solitary toxic nodule. You can see in the scan. Thyroid gland is here. This is the thyroid gland which is not taken as dye. This technetium is taken by this. So this is a nodule. As the previously discussed, don't treat with an anti-thyroid drugs. Go for radioactive ablation or surgery. So this is the importance of checking a neck examination. Ask the patient to extend the neck. નીચે નહીં, થોડી ઉપર કરશો તો વધારે દેખાશે. એક થાઇરોઇડ પેશન્ટ અગેન કે ભાઈ સ્કિનમાં સાહેબ થોડું ઇચિંગ થાય છે. We seen the hands, explore the other areas. What is the diagnosis? Thyroids with a skin lesion. It's a dermatitis herpetiform, celiac disease સાથે associated with. Two brothers. Generally, young patients don't have goiters together. These are the brothers. Goiters young age ma together na hoy. So this is like a case of a thyroid hormone dysharmonogenesis where you have an goiters in a young age. Spot diagnosis again. I'll see if I'm able to do it or not. When you examine the patients, they developed an pain over the neck. When you touch it, perfect. I'm skipping some of the slides. Any abnormalities in the hand? Nothing? Okay. So this is the tendon, which is a prominence. Okay, that's called a Dupuytren contractures. At present, there is no abnormality, no contractures in the hand. But if you know the disease, you can pick up on a time, ask the patient for some physiotherapies and consultations. You can prevent this kind of a contracture in the future. So this is called a Dupuytren contractures. Last slides in my talk. Two diagnoses from this image. This patient is diabetic. Regular follow-up માં આવ્યું કે મેં કીધું આ પગમાં શું છે કે સાહેબ આવું તમારે થાય રાખે, અમારા ગામડામાં હોય, તમે ચિંતા ના કરો. One diagnosis is confirmed patient has a neuropathy. બરાબર, એ તો કન્ફર્મ થઈ ગયું કારણ કે એને કાંઈ ચિંતા નથી, એને ખબર જ નથી શું થયું. There are some linear lesions in the hand, in the leg, a finger, and some deep bleedings, and in the top of the both legs. Right? Typically, in the literature I found yesterday only, I've seen there are, it is typically reported કે ભાઈ linear lesions હોય, both the legs માં હોય, very in the depth માં હોય. બરાબર છે? So, diagnosis is, as I said, the neuropathy is definitely there, sensory neuropathy. It's kind of a bite, okay? So this is a rodent bite, all right? So I'll give you a lesson that you just search Google that rodent bite in diabetic foot patients. You will get a typical kind of image. મને નહોતી ખબર, મેં જોયું પછી ખબર પડી કે આટલી typical image આપણી પાસે છે, right? Because what they do એ ફૂંક મારતા જાય સાથે સાથે અને એને કટ કરતા જાય એટલે they don't feel a pain of it. So this is the patients with rodent bite in diabetic patients. So sometime images reveal the diagnosis. That was my last slides, and thank you very much for the patient listening. Thank you very much.